Hi, and welcome to the Dr. Coffee Podcast. And this Espresso Shots episode of the podcast is prompted by a video that has gone viral in South Africa over the last few days. It's a video that's been shared by a patient named Tom Helen about his experience at the Helen Joseph Hospital. And if you've been living under a rock and you haven't seen this video, we will link to it as well as some of the other videos around the situation. And we're going to analyze the situation a little bit without going too in detail, but just as a junior doctor to kind of critique it, look at the situation and what we need to take from it, what we need to learn from it, how we can respond as professionals, healthcare professionals in South Africa. My name is Simon and I'm from the Dr. Coffee Podcast, and it's important that I state from the outset, number one, that we want Mr. London to get well. So Mr. London, if you happen to watch this or anyone watching this video, please understand we don't wish anyone ill, and that we as doctors, we do want our patients to get better, and we certainly want Mr. London to make a full recovery from the pneumonia and the chest infection that caused him to be in the hospital in the first place. I have a number of hats, a number of roles, and I want to state that this video is not speaking out of any of those roles. I am a doctor in the public service. I work at Klerksdorp Hospital in the Northwest Province as a community service doctor, and I'm not speaking on behalf of the Northwest Government, the Department of Health, or Klerksdorp or any of my colleagues in that hospital. I'm also a graduate of WITS, and I'm not speaking on behalf of WITS, who have also made their own statements about the situation. And I'm also a member of the National Executive of JUDASA, the Junior Doctors Association of South Africa. And I'm certainly not speaking as a representative or on behalf of JUDASA, which is a subcommittee of the South African Medical Association, or SAMA. Again, not speaking on behalf of them. What I am speaking out of and who I am speaking on behalf of is just our community of junior doctors. That's everyone from medical students to interns and ComServes, and the people who have been a couple of years post-ComServe. Anyone who's working in public service or is just starting out in the career would qualify as a junior doctor, somebody who's not yet specialized, not yet become a consultant, and is kind of in those junior levels, doing overnight calls in the hospital, working oftentimes in very stressful situations, under-resourced situations, long hours. We've heard about 30-hour calls, sometimes 36-hour calls for doctors, and so on. It's out of that we want to bring some perspective, maybe color to the situation. And also, I think it's necessary to acknowledge some of the points that Mr. London raised about us as professionals, about us as junior doctors, and what we need to take on the chin, what we can learn from, and how we can improve. So let's get into it. So in the first phase of this video, we're just going to briefly recap the main video that's doing the rounds, because there are snippets and there's also a longer form video, which I'm going to link to in the show notes for this episode, which is an 8-minute video. But there's essentially a 5 minutes something video bouncing around, which is like the core video that's gone viral. And in that video, Mr. London expresses his deep frustration with the treatments of patients at the Helen Joseph Hospital. He likens it to how cockroaches should be treated, that there's a complete lack of any personal interaction from the doctors. They don't greet you, they don't know your names, they don't let you know their names. And he describes a pervasive atmosphere of disrespect and disdain towards patients, like, oh, why do you have to be here? Treating every patient like they're a hobo, he says. And that he has never witnessed this level of disrespect. And it extends from medical students from WITS all the way up to the consultant specialist physicians. He shares his experiences. So like he went for a CT scan and there was a mistake and he had to have a repeat scan. And then interestingly, he mentions his interactions with two specific doctors. And by all means, Dr. Pillay and Dr. Van Eck, it seems, have given a good account of themselves. They've been consistent in updating him of their progress. He's got some level of rapport with them. But he contrasts that with a young female doctor who, the way he describes the interaction, basically just looked him in the eyes, looked at his notes, and didn't speak to him for 10 minutes while she wrote, and then basically said, like, oh, you have a new doctor, and didn't really give a good reason why, or one that satisfied him at least. He mentions that the doctors treat patients with a lack of empathy, and that they are dismissive towards patients in pain. So a patient is crying out in pain, and the doctor's kind of like, okay, cool. And then he goes on to do a tour of the ward. There's probably so much to cram into a video that I don't think it's fair to criticize the way that Mr. London has approached the video. He doesn't have the benefit like I am now, sitting in at a desk and able to edit it. cut things out, give something structure, benefits of hindsight that I have. I think that he's trying to organize his thoughts, but he's also being bombarded by oh yes, I need to do this, and don't forget he's also sick. He's unwell, so maybe not necessarily able to frame things in the most succinct way. So it's fair that he's bouncing stuff around and that he can go from doctors to the ward and then back to the doctors without necessarily making doctors responsible for the ward. And he points out some infrastructure issues. So the plugs aren't working, the taps aren't working, the walls or the roof is peeling, things like that. For anyone watching, anyone listening, it's important that you realize that doctors have to work in that environment, whether they like it or not. We can complain about that. We can say, the ward needs a lick of paint. We can say the wards need a plumber to come. But just because you as a doctor raise that doesn't necessarily mean that it's going to happen. Please understand that if you have a frustration about toilets not having seats, we just as much have that same frustration because we want the best for our patients. And we're working day in, day out in an atmosphere of, I think it's fair to say, a lack of excellence. So you're trying to bring excellence, but all around you, there's this subpar, sub-average, no motivation to make things better, which is deeply, deeply frustrating and almost harmful to your psyche because you're trying to do the best you can with what you have, and what you have is very, very little. On the note of procurement, as I mentioned, doctors aren't involved in procurement, and it's even to the point of the syringes or the IV cannulas, the vacuolators of fluids that we give you in the ward. Doctors aren't actually able to place those orders. That order comes from somewhere else sitting at a desk. And oftentimes, it's a person who is choosing a product based on the price per unit. So they will go for the cheapest or for the contract that makes the most sense, but without actually looking at what is best fit for purpose in the ward. What do the doctors want? What works for the patient population? That's important because sometimes you might think that the doctors are working with substandard equipment because we don't want to waste our money. It's not our money. It's money that gets spent on our behalf that we then need to come up with, the best solution we can using the tools that we're given, which are often not what we need, or, we have to make a compromise. We have to also rationalize the budget that's spent with the most people helped. So sometimes it's also about extending help to the most number of people. So you might have a substandard IV cannula, but you know that those cannulas are only going to be used for 36, maybe 48 hours at a time, and you're going to be able to help more people. So in a resource-constrained setting like South Africa, there is obviously that. A corollary is, of course, corruption. And while there are some doctors who have been caught out being involved in corruption, we also need to realize that many, many doctors are not involved in corruption, and that we are the victims of corruption just like our patients are. And we are victimized if we call out corruption, if you point out an irregularity, if you blow the whistle, if you are honest. You oftentimes get victimized or you get called a problem. And this is not to say that corruption is systemic. However, it is in the system. So it's important to recognize that and attribute responsibility where it's due. So a doctor is not responsible for a leaking tap, is not responsible for flaking paint, is not responsible for no pillows or no blankets in the ward. Those are all outside of the scope of what the doctor is responsible for. You will find many good-hearted doctors that will go to another ward, or will go to a supply store and then find a pillow, find a blanket, but realize they're taking time away from their actual responsibility to go do that. They're risking other patients being upset that they're not being helped because they're getting you your pillow. Again, this is such a complicated situation, but it's important to define what the doctors are responsible for and what is in their control and what simply isn't. So just to summarize, the reason this is important is because about 3 minutes into the video, Mr. London walks into the ward and he says doctors are despicable because, look at this ward, look at the poor conditions the patients are working in with the malfunctioning taps and things like that. But that's simply not what the doctors are responsible. We can't be despicable human beings because of malfunctioning taps. It's difficult to say, but it's not something that we really have control over. Outside of us going to Builder's Warehouse and buying parts and fixing those taps ourselves, there's very little we can actually do about it. Even if we raise it to the ward, even if we raise it to the facilities managers at the hospital, and you remind them that's not something that we can actually change. And it's very frustrating because you go into the system and you're fresh and you have energy and you're a bit wet behind the ears and you want to make a difference, you want to bring excellence, and you're so disheartened because there's very, very practical ways we can improve the lives of our patients. And it seems so simple, it's just there, it's just out of reach, and you can't make it happen. On the topic of the young patient that died, so Mr. London pointed out that a patient near him had passed away in the ward. Now, in the short video, you see he mentions that the patient had died and that the doctors were there at the bedside and he's been dead for 20 minutes. In other videos, he mentions that, number one, the doctors had already determined that this patient was terminally ill with liver failure, that he wasn't for escalation of care, and that even though he wasn't for escalation of care, they still conducted a 30-minute recess, and a proper recess. The doctors were there. Mr. London describes that they acted in a coordinated and organized fashion. They recessed it appropriately. And then at the end of the 30-minute recess, they kind of walked off, and there was laughing and joking about trivial things at that point, after they had already made an effort to resuscitate this man. So on the one hand, in one of the videos I saw, Mr. London was criticizing the application of resources to what he deemed a futile situation and saying, why did they spend so much time trying to resuscitate this patient that they had already determined was not for escalation of care? That's the first thing. And then the second thing is he was criticizing them for walking off kind of laughing in the face of this obvious tragedy, and something which might be common to doctors working in a hospital setting. Less than half of resuscitations in a hospital setting are actually successful, but obviously it's not familiar to him. So he's in this shocked state, like, oh my gosh, I just saw somebody die. And in that situation, he's like, why is the body still here? So maybe it's worthwhile pointing out that, again, it's not the doctor's responsibility to take the deceased patient out of the ward. And even more than that, we're actually not allowed to just take them out of the ward. As uncomfortable, as unsettling as it might be, there's actually a legal process related to the moving of a dead body. So we as doctors are allowed to declare the patient dead. We have to write good notes. We fill in the BI death notification. But outside of that, you're not actually allowed to tamper with the body, because many times there will be cases where an autopsy is performed to determine whether there was any medical negligence, to determine if the doctors acted in the best interest of the patient leading up to those final minutes. So we are actually under a legal mandate not to interfere, because if I so much as take a drip out, somebody might say I was trying to hide evidence, or they might say that I was trying to hide my responsibility. The mortuary team, the nurses, they are responsible for moving that dead person, and there's a whole process related to that that's outside of the scope of this video, and quite frankly, I don't fully know the details of, but it's fair to say that even if the patient was there for a few hours, whether you're in a private hospital or a public hospital, there are still protocols and procedures in place that have to follow, otherwise you're basically at risk of breaking the law. So this is something where I feel like you damned if you do, damned if you don't kind of thing, because if you move the body quickly, then somebody would say you're trying to cover things up, that you were trying to hide blame or attribute blame to somebody. And if you don't move the body, then you are negligent, you're causing harm to patients. It's such a tricky situation to be in. Maybe a little bit unfair to criticize the doctors that the patient had been lying there for 20 minutes. Definitely, we can say something about the doctors walking out laughing. That doesn't make a good impression on people. Even if it was just a way of debriefing, blowing off steam, I think it's important that you're a human being and you have an opportunity to kind of vent your emotions. Resuscitation, especially resuscitation of a young patient and a failed resuscitation, can have a big impact, and it's definitely not something that we are lighthearted about. It's just a pity that in this situation the gravity wasn't maybe fully expressed, and maybe the team went and debriefed elsewhere where they did talk about the seriousness of the situation, but obviously Mr. London witnessed this and it's made an impression on him, and a negative one at that, and he's fully justified in expressing his view and saying, guys, this is not on. And then towards the end of the video, we get to the actual crux, the actual thrust of what Mr. London was trying to communicate and also what we need to take to heart and what we need to respond to. So number one was the lack of compassion that he felt was expressed by the doctors in the hospital. And in other videos, he mentioned that at the emergency departments, he felt like there was excellent care. The doctors were compassionate, they were caring. They said to him, Shame, we've taken 600 mils of liquid out of your lungs. You're breathing a bit better, but there's still a lot of fluid there. There's a good chance you have another liter and a half of fluid. Now, for somebody to have 2 liters of fluid as a pleural effusion, they have to be very, very sick. It doesn't matter what the cause is, whether it be a endocrine cause or an infective cause or a neoplastic cause. The point is, he was very sick and he received clinical care. And he has actually responded and said, I didn't want to condemn the clinical care. I think the care was okay. The doctors were just very disrespectful and rude. And this is where I need to kind of bring the counter and say, 4 times in this video, he accused doctors of experimenting on patients. And that's something we can't just take lightly, because you're portraying doctors as being a little bit haphazard, not necessarily knowing what they're doing, certainly not being professional carers and doctors and following good evidence-based medicine, but rather doing experiments. And experiments that are harmful to their patients is the connotation or the implication there. And I think this is very dangerous talk, and I'll explain why. Number one, we live in a day and age where people are already mistrusting our public hospitals. They would rather go to a traditional healer, a sangoma, or quite frankly, their aunt with bad medical advice than go to a doctor at a public hospital, because they've heard horror stories. They've heard if they're going to get admitted, they're never going to come out alive. And when you kind of repeat that trope or you build into that stereotype, that's very, very harmful. There are many people who have been helped and healed and made better, and their lives have been improved by public hospitals. And doctors, all the way from an intern all the way up to consultants, will tell you that they have good days and bad days, but we're all trying to do the best we can for our patients, to perform and practice evidence-based medicine, and generally trying to not hurt our patients, okay? Of course, there are mistakes that could happen. Of course, there are tough situations where words can be exchanged. There are personality clashes on the team and between human beings. But overall, I think it's dangerous to say that we are experimenting on patients and that we're despicable human beings. There's the expression, 2 wrongs don't make a right. So just because you feel that you've been mistreated or you've been disrespected doesn't mean you should now disrespect and mistreat healthcare professionals, call them despicable human beings. At one point, he says that they don't deserve to live. He says, you doctors in the Circus Hospital, you don't deserve to live. Wow. I don't think there's any doctor who has said that about patients. If they have said that about patients, there's a serious issue. Those doctors need to be identified and held to account. Likewise, any patient who says that about the physician who's treating them to the best of their abilities in an under-resourced setting, in a stressful situation, also needs to be held to account to their words, where you say, hey man, it's not okay to call doctors despicable human beings. It's not okay to say 3 or 4 times on your video that they're doing experiments, but certainly it's okay to say, guys, you need to catch a wake-up call. You need to treat your patients kindly. You need to treat them with respect. You need to greet them. Absolutely back that statement, and we're going to unpack that a little bit more. So speaking as a junior doctor, speaking as somebody who's doing community service, who's just come through internship, speaking as somebody who has studied at Helen Joseph. I've never worked there as a doctor, but I've been at Helen Joseph as a student rotating through the wards. I know how hectic it can be to be looking at blood results and trying to make good medico-legally appropriate notes and finish your ward round before the consultant comes, and at the same time be a good human being. And guys, we do get this wrong. I have seen it. I have been a part of it, unfortunately, and I've caught myself out where we get so locked into our notes and we get so locked into checking blood results on LabTrack that we forget to greet our patients, that we forget to ask them about what we spoke about yesterday. We forget to check how they're feeling after the operation. It's not necessarily medical negligence, but it is just pretty swak. It's poor of us, and this is where I think that we can definitely improve. I don't think anyone can object to Mr. London saying, guys, you need to greet me. You need to introduce yourself by name. I don't think anyone in their right mind can say, as a doctor, I don't need to treat you as a human being. It's a patient-doctor relationship, and that's the way it is. There's definitely a power dynamic. And this is where I think that it's kind of like eating a meal of fish. Bear with me through this analogy, but if you're eating seafood and there are bones in your fish, you don't just swallow the whole fish whole. You obviously eat the fish, but you leave the bones on the plate. And maybe some of the ways that Mr. London was conveying his frustrations, maybe the way that he went about posting the video was to stir up anxiety and was to stir up a response and was to point out failings of the system. And that's kind of like fish bones. But the meat for us as young doctors is to say, okay, how can I improve in the way that I conduct myself as a young professional? There were a number of claims made in the video by Mr. London that I want to kind of circle back to and just almost fact check. But I highlight them because it's all about perception. It's all about the impression that one gets. So he speaks about the patient who was getting a lumbar puncture and 5 doctors were around to perform a lumbar puncture. Now, if you've worked at Helen Joseph, you know that there's not even 5 intern doctors in a unit. So there was not 5 doctors available to do a lumbar puncture. Most likely, there was 1 intern or maybe an intern and an MO and a couple of medical students who were witnessing the procedure and learning about how to perform the procedure, because Helen Joseph Hospital is an academic hospital. There's signs up that say this is an academic training hospital affiliated with Wits University, which means that there's a good chance that your medical procedures are going to be performed by a medical student under supervision or witnessed by a medical student. So for all intents and purposes, and just what I know about Helen Joseph, I'm going to go out on a limb and say most likely this wasn't 5 doctors doing a lumbar puncture. We don't have those resources. It was most likely 1 or 2 doctors surrounded by medical students who were there to support and to witness and to learn from them how to do the procedure. In our setting, we do not do lumbar punctures the best way possible. I say we don't do it the best way possible, which is not to say that we do it wrong or we do it in a way that harms patients. We certainly do it the best way we can in the setting we have. And that's the definition of excellence, right? Doing the best you can with what you have. If you go to a private hospital, guaranteed it's going to be done by somebody with loads of experience, possibly even either an anesthetic doctor or a neurologist. In a public hospital, your lumbar puncture is typically performed by a junior doctor who is still going to take aseptic and sterile precautions, who is still going to perform the procedure the same way, but definitely has less experience. And this is not to say that the patient is going to be placed in undue risks. It's just that those hospitals are manned by junior doctors. Whether it's for moral support or to check that you're doing the right thing, many times these procedures like lumbar punctures or an anesthetic tap or a pleural tap, which is like the one that Mr. London received, will be done by more than 1 staff member or clinician at the bedside. So again, having 5 people there, it wasn't a waste of resources. It wasn't inappropriate. It was maybe just misunderstood or misperceived in that context. As for talking about food and restaurants, talking about cars, unfortunately, guys, this is when we have to cop on the chin because it's probably not the best setting to be talking about those things. Yes, we're allowed to talk about cars and restaurants and entertainment and clothes at work, of course. But should we be doing those things while we are at the bedside, while we are performing a procedure? I'll leave it to you to be the judge. But my personal opinion on this is that it's possible for us to do the procedure better if we're not distracted with a conversation about those outside things. We might get work done faster. And I've certainly been guilty of trying to make small talk with colleagues at the time where you actually should be invested fully into the care of your patients. So that's something we can all learn and grow in. And the only thing I can say is that, but most of us are young and in our 20s, and we're still thinking about the things that young people in their 20s are thinking about. And it's just a sense of professionalism we need to learn, and aspects of professionalism where we say, okay, this is fitting for this situation. This maybe needs to wait a bit. I can talk about this, but this, there are ears in the room and there are people watching, and we need to just hold ourselves to account. As I've mentioned, it's so important that you introduce yourself to your patients, that they know who you are and why you're involved in their care. And patients have a right to know why tests are being done, what the results are, what their options are. Patients have a right to voice their concerns. So no one can actually fault Mr. London for raising his concerns. The only thing we could maybe say is the way he did it wasn't appropriate. He didn't follow the right channels, or the language he used was a little bit hurtful. It's not fun to be called despicable and to say that we don't deserve to live. And the other aspect, obviously, is we need to also consider our own mental health in all of this and the situations we're working in. It's not fun that we're working 30-hour calls. I've recently been reading a book by Adam Kay called This Will Hurt. It's basically his misadventures in medicine as a junior doctor, doing these 30-hour calls, some of the patient interactions he's had, and patients and doctors alike would do well to read this book and relate to the situation and see what it's like to actually work in medicine. He ultimately went to leave medicine, and there's a reason why 2/3 of the doctors who finish ComServe, only 2/3 of them go on to register as independent practitioners. There's a reason that only 70% of doctors are staying in medicine, and the other 30% are saying, I want no more parts of this. I would rather take my medical degree and go and work in finance, or go and work in policy, or go and work in something else, but I do not want to touch another patient as long as I live. So guys, just to kind of summarize everything, Mr. London shared his frustrations with how he and other patients were being treated and the conditions in which they were being kept. And I don't think that it's fair to hold the doctors to account for the conditions necessarily, but we can hold ourselves to account for the way that we speak, for the way we are conducting ourselves, the way we're perceived. We are responsible for the words that come out of our mouth and the way that we say them. We are responsible for the way that we greet patients, and as can be shown by Dr. Pillay and Dr. Vanek, who had a rapport with Mr. London and clearly were speaking to him, it's quite possible to have that rapport even in stressful situations. It's possible to talk to patients, and even though they're in a negative situation, for them to overlook it because the doctor is making an effort. For them to say, hey, you know what, this really sucks. I don't want to be here. But because I can see that the doctors have my interest at heart, that they genuinely care, I'm willing to overlook stuff. It's when they feel that the doctor, who is seen as the leader of the healthcare team, who is seen as the responsible person for the hospital, when they see that that person doesn't have empathy, then there's nothing that can redeem the hospital at all. The hospital becomes a circus, it becomes irredeemable, and complaints are made. So what we as junior doctors need to kind of receive from this is we all need to grow in how we talk to one another, how we talk about patients and to patients, and how we conduct ourselves, just simple manners, harking back to the Batopile principles and the human rights that we have up on our walls in the hospital. Wherever you're walking, whichever corridor you go through, whichever ward you go in, there will be the Batopile principles. And this is not something that's only for Gauteng. This is not something that's only at Helen Joseph. This is something that's systemic. When you go to a petrol garage, when you go to a police station, when you go to a restaurant, how many times can you say that you genuinely felt welcomed and that there was good customer service? We're not good at customer service in South Africa, across the board. If you go to other countries, go to America, and I've never been there, but if you see the level of customer service that they have, that is what we should aspire to. We can create such a good impression, even if we are working in an under-resourced environment, even if we're tired. Guys, even if we're tired, we're so tired that we want to cry, it's still possible for us to be kind, for us to take 10 more seconds and listen to a patient, commiserate with a patient, to summarize back to them what we believe they are trying to say to us so that they feel heard. I know that many of us have paid out of our own pockets to buy meals for patients, to buy clothing for patients, to give them taxi fare upon discharge. I know that. And I'm not saying that we need to do more of that, or we must highlight that. Maybe it's as simple as just a smile. Maybe it's as simple as just choosing to be lekker for one more person. Let me know what you think, because maybe I am just looking at this through rose-tinted glasses and I am naive to the situation. I certainly think that Mr. London has made it difficult for himself, because think about it, like whenever he goes to a healthcare facility now, they're going to feel like they're under scrutiny. The staff there are going to worry, and he'll never know if it's genuine care or not. Like if somebody's like, hey, Mr. London, hi Tom, how are you? And they take a genuine interest in his care, he's going to be like, oh man, I know this is because they saw that video. So please, Mr. Tom, if you are watching this video, we genuinely want you to get better. I pray that it's nothing serious, that it's just a pneumonia, that your CT scan came back fantastic, that you're doing well, better and better by the day, that you make a full recovery. Hopefully this goes some way to show that as junior doctors, we are not too proud to take correction. And I say junior doctors because junior doctors are the doctors that are keeping the wards running. Junior doctors are the ones that are interacting with patients daily, that are in the trenches, really dealing with the patients from the ED to discharge. I think that it's important that we are able to look at the situation and see, you know what, this is an opportunity for us to show our true character, to not get upset about somebody complaining. He has a right to complain. Whether or not he complained correctly, totally not the issue. The issue is, can we improve in the way that we speak to patients? Are some of the things that he's highlighting, do they ring true? Are they things that stick? And the truth is, they do stick. Not to everyone, not all the time. No one's 100% bad, but we're not all 100% good either. So we need to take what we can out of the situation, apply it, and maybe for the next few days, hold each other to account. Let us make an effort to focus on the patient, to respect the patient, to give them the best we can. And there will be times when our safety is going to be at stake. There will be times when we get belligerent patients, and maybe we need to do another episode just about that, because I think one of the realities also is that every single one of those doctors working at Helen Joseph who came under flack by Mr. London and in his video were called despicable and lacked empathy, every single one of them work in a setting where they're at risk. They're exposed to harmful diseases and their own personal safety and their health is at risk. They're exposed to violence and intimidation. We've had situations where, not at Helen Joseph necessarily, but situations where mafia have broken into hospitals and held people at gunpoint while they ransacked the place. We've had places where doctors have been hijacked, robbed, and even raped in our public hospitals. Certainly, doctors are at risk as well. Maybe we should do another episode about that, because we've spoken about this at length today. This episode has carried on for a long time, but hopefully we've kind of unpacked it a little bit. Let me know what you think in the comments. It would be good for us to get balanced comments from junior doctors. Maybe even some of the doctors from Helen Joseph want to speak about the situation, speak about their response, how they're feeling about being singled out, in this situation. If you're a medical student at Wits and you've rotated through Helen Joseph, what do you think? How is this going to frame you as a future healthcare professional in our country? And this is one of the first times that I've done a vlog content episode like this, so let me know what you thought. If I rambled on, I'm so sorry. Once again, a little disclaimer, this is just coming from me, not from any of the organizations that I represent or am a part of. Thank you for listening to the Dr. Coffee podcast. This video is available on YouTube as well as all of our social media and our podcast platforms. Until next time, stay safe out there.